Is it true that amblyopic eyes have reduced accommodative attitudes? No, it's not true. Not not each amblyopic eye has an accommodative default, but some amblyopic eye may be amblyopic because of an, an accommodative insufficiency. This particular form of accommodative disorder is called as accommodative lag. The accommodative lag is like a gap in the accommodation. For example, when one eye needs to focus something at short distance, which is 30 centimeter long from the eyes, it's needed to accommodate for 3 diopters. In case of of an accommodative lag, it's needed to the accommodative lag will allow just 1.5 diopters. It will not cover the total amount of diopters which is needed for the defined distance. In these cases, what should be done? It's not clear. There is not evidence in the literature in these cases because not a lot of people who check who are responsible for amblyopia treatment are checking the the accommodation, or is checking that not in the proper way. Which is the proper way to check the accommodation? The proper way is to check it monocularly. You need to close one eye and with through the dynamic retinoscopy, it's needed to check the accommodation. If it happens that one eye is accommodating well, usually the non-amblyopic eye, and the other eye, the amblyopic eye, is not accommodating well, like as it will be seen by Down syndrome, then you can suspect two things. Or the correction is not properly, the optical correction for the glasses or contact lenses is not properly, or we are in a case of lack of accommodation. When you are dealing with a lack of accommodation, what should be done? In these cases, if you just try the traditional occlusion therapy, you will not have a lot of success, because when you close the non-amblyopic eye, then the amblyopic eye will see blurry at short distance because of the accommodation lag. And since the proper vision at short distance is important, is fundamental for the development of the eyesight, then the traditional occlusion therapy will not work, since there is the accommodative lag. What should be done in these cases? It's needed to offset the accommodative lag. It's needed to compensate the accommodative lag through plus lenses, lenses which will occur for the lag, for the accommodative lag. I have just had one case of that. I mean, I have just seen one amblyopic child so one amblyopic eye with a lag of accommodation, and he is 9 years old. This child was in treatment since he was 2 years old, and after 7 years of treatment, the therapy has not worked enough. The amblyopia is always here. And yes, let's try, even if the age is not really proper, and then I will report the result. I will check in other children if it will happen too. Note of word is that some orthoptists believe that the microstrabismus could happen even if the lung test is positive, if the lung test lung card will be seen. In these cases, when you don't notice any strabismus and you suppose that there may be a microstrabismus with identity, you should carefully check the accommodation. I suppose that the problem is this one. It may be this one. It may be the accommodative leg. It's not microstrabismus with identity, because the lung chart test will be seen. There is stereopsis. It's not so well, but the stereopsis is not so well anyway because of the eyesight. The stereopsis is directly proportional to the eyesight. It doesn't mean, it's not that the stereopsis is not well because of the strabismus. The stereopsis may not be well because of the eyesight. If one eye is amblyopic, it's normal that he will not see this eye will not see 60-second arc of stereopsis, will see 240 or 120 in correlation of the amount of amblyopia. You can just check this by yourself when you are dealing with a pure refractive amblyopia. If a child receive for the first time the glasses, and you check the stereopsis with the TNO test before of putting the glasses, it will be so that the stereopsis will be 240 or 120. When he will be put in glasses and checking that the amblyopia is away, then the stereopsis will improve. And then that's a demonstration that is not always the microstrabismus the cause of a reduced stereopsis. Per experience, I have never seen a child with microstrabismus who is able to see the lung test. What do you think about it? Let me know, and we will see us soon in the literature when I will report the result of this clinical case.